Hello and welcome. My name is Devin Anderson, and I am the engagement coordinator here at the American Association on Health and Disability. I am a white woman with long dark blonde hair. I am wearing pink half-framed glasses and a tan top. I am joined by my colleagues, Michelle Sales, Nuria Paracha, and Cassandra Moore, who will all be helping out on the back end to respond to any accessibility needs or questions you may have throughout today's webinar. Please send any accessibility needs in the chat. Thank you for joining us in the second conversation in this year's Disability and Health webinar series. We are looking forward into diving into a robust conversation today around non-apparent disability and autoimmune conditions today. Autoimmune conditions are considered to be under the disability umbrella. We will be discussing autoimmune conditions as invisible or non-apparent disabilities. We recognize that these terms may be considered incomplete and could imply that the disability does not exist. And so we're always looking to the community for guidance and expertise on how we continue to talk about these conditions. We understand that non-apparent may be the preferred terminology, but that the language is still ever-changing. Speakers may oscillate between these terms during today's conversation as well, so feel free, panelists, to use whatever terminology you're comfortable with as well. We also want to talk more about the research that examines these factors and what's being done with the All of Us research program. Stay tuned for more conversations in the coming year as we continue to explore health questions around disability, social drivers of health, and inclusive research. This event is brought to you by the American Association on Health and Disability as part of our Disability Community Engagement Health Partner Project, or DCEPP. This initiative is working to involve the disability community in health research with the All of Us research program. All of Us is an initiative to engage 1 million or more people in health research to improve individualized healthcare for all. We hope you'll consider signing up to participate in the program, and we will be sharing information about All of Us in the chat throughout the event. You can learn more and register for the program at the links that we will post in the chat throughout the webinar. And now for some housekeeping. This webinar is being recorded and will be shared publicly after the event. We have closed captioning and ASL available. Please notify us of any other access needs or troubleshooting in the chat. We also want to remind our panelists to speak slowly for the ASL interpreters. We hope you'll participate in our evaluation survey, which will appear in the chat and should have popped up in your web browser. Please let us know your thoughts on the series and if there are any future topics that you would like us to cover. I'd like to take for a few minutes now for you guys to get to know the panelists before we begin our afternoon here together. We have Jen Williams. Jen is the director of the Maine Silk. Jen was just 33 years old when she had a thalamic ischemic stroke in 2016. She has spent most of her life trusting healthcare providers, which, as you may imagine, came crashing down as she began to more deeply navigate the Maine healthcare system. After years of figuring out things on her own, she is now on a mission to ensure that other brain injury survivors get the health care that they need and deserve. Jen is the executive director of the Maine Statewide Independent Living Council and is the co-founder of the Middle People Project, a nonprofit that aims to create a hub of resources for brain injury survivors that don't qualify for many state and federal services. Next, we have Ashley Brady Kelly. She is a support line operator for Pathways Vermont. She has a bachelor's of social work, and her personal interests are inequity, disability awareness, and critically reflecting on and challenging societal barriers and factors that contribute to their ongoing influence in our society. She has lived experience as a person with a disability, which has opened her eyes to this work, and her own personal drive is what has kept her motivated to continue working toward a future of hope for the community, and continues on in all of the work that she's been doing to help alleviate some of those barriers for the community. Next is Jess L. Wilcox Cowing, multiply disabled scholar and educator who teaches disability studies for the University of Wyoming's Disabilities Studies program and is the self-advocate discipline lead for the Children's National Hospital Leadership Education in Neurodevelopment and Related Disabilities Fellowship Program, also called LEND-CN. The research is in the areas of 19th and 20th century literary studies, feminist disability studies, and settler colonialism. Their work is published in the Journal of Feminist Scholarship, Disability Studies Quarterly, and CUSP, late 19th, early 20th century cultures. Jess grew up on Wabanaki homelands and lives and works on Piscataway homelands. And we have Dr. Natalia M. Rivera Morales, and she is a Mellon Postdoctoral Fellow in Disability Justice at the George Washington University. At GW, she is building competency in disability conscious approaches to universal course design. She holds a PhD in Hispanic languages and literatures and a doctoral certificate in gender, sexuality, and women's studies from the University of Pittsburgh. And I will be your moderator for today's conversation. So you will see me pop up throughout the conversation to sort of help the flow of things. So let's get to know the work of the panelists. So if you don't mind, if you can start up with the physical description, and I'll start with Jen, and we'll kind of ping pong down the list just real quickly, briefly. Start off with a physical description, and before your presentations here, just touch on how the topic of the day in autoimmunity and disability intersects with the work that you do. So Jen, we'll start with you.
Thanks, Devin. I'm Jen Williams. Thank you for reading my bio, Devin. I am a white woman in my 40s with red hair. I am wearing a green shirt with a tan scarf with a blurred white background. As Devin mentioned, I am the executive director of the statewide Independent Living Council in Maine. And as a brain injury survivor, I am able to translate a lot of my own experiences and experiences of other survivors that I've met through support groups into my work. And I'll touch on that in my presentation on how those kind of intermingle. But really, I'm just passionate about helping people and spreading awareness.
And Ashley, how about you?
Hi there, my name is Ashley. I'm a white woman who is wearing a black-based pink and white and orange flower dress, and you can see me in front of a brown door. I am really passionate about this work as somebody who lives with multiple invisible conditions as well as a physical disability. But I learned as I was diagnosed with POTS a few years ago that the societal attitude towards my physical condition, which is very visible, is very different from my condition that is invisible, and the treatment is vastly different. So for me, it's all about how do we kind of bring awareness and marry that just because something is invisible does not mean it's non-existent or doesn't have an impact for the person experiencing it.
Great, thank you. It's very true. Thank you for sharing. Jess, how about you?
Hello, this is Jess. I am a white person who's 40. I wear glasses. I have brown hair. I would like to point out I am wearing a t-shirt that says personally victimized by my own immune system. I got this from a disabled creator on Etsy. And that's a good segue into how this figures into my work. It actually kind of like strangely doesn't. I'm an academic and I research and teaching in a bunch of different areas. I'm also a person who lives with an autoimmune condition, among other things. And so this is actually very personal for me. It's not really related to my work, but maybe more in the realm of advocacy that I do, and just something I'm passionate about in general. So thank you for inviting me.
You're welcome. Thanks for being here. And Natalia, how about you?
Hi everyone, this is Natalia. I'm so happy to be here. Very grateful for this invitation. So my pronouns are she, her, hers, and ella. So I am a Puerto Rican woman in her mid-30s. I have kind of dark brown, almost black hair. And I guess I'm light-skinned, but sort of with an almond tone to it. And I'm wearing a wine-toned blazer. Sort of akin to Jess, the topic of autoimmunity is very personal. I do have psoriasis, and as I've learned more about that condition, I'm also learning about the link between psoriasis and autism spectrum disorder. I was just diagnosed back in May, and in my dissertation, I do touch on the implication of transgenerational trauma in the development of autoimmunity. So, but only very briefly, but that's how that's related to my work.
You. Sorry, I lost the unmute button there for a second. Thank you all for sharing. I'm looking forward to the rest of this amazing conversation. So we're gonna get started with Jen Williams. I'm gonna share my screen so that we can get to her slides. Are you all able to see the slides?
The bottom is cut off a little bit.
Oh,
Perfect.
good there?
Perfect.
Okay, let me know when to scan and you can feel free to go.
Thank you. So again, hi, I'm Jen Williams. I am a born and bred Mainer, lived here since I was born. I had a stroke at age 33. They believe it was caused by use of contraceptives and migraine medication combined with family history. I don't have high blood pressure. I actually have really low blood pressure. I don't have diabetes or, any clotting risks that they have found. So that's the idea of where that came from. I hear a lot that you're all healed now. You look great. And I wanted to talk about the invisible disability part of things. There is a little bit of connection in autoimmune disorders that happen after disability, after brain injury. But I just wanted to talk more about the invisible part of things, and how that, determines how we interact with the world, really. You can go to the next one, Devin. So what we experience having an invisible disability, people don't understand what they can't see. They aren't living with it. I remind people all the time, people aren't living in your head. They aren't living with your disability. So they will forget. It's not a day-to-day for them. And my family is, I don't want to say guilty of it because it's not like something to be guilty of, but my family isn't living with it. So when I go see my family for Christmas, they don't necessarily remember because I'm not in a wheelchair, I'm not using crutches. They don't recognize that there are invisible challenges, which I have listed them there for you if you feel like reading through my invisible disability list. We're often dismissed or not taken seriously because of invisible disabilities. We face a lot of assumptions and a lot of judgments, and there tends to be less resources. In my experience, there tends to be more resources for people if you have a physical, apparent disability than a hidden invisible disability, particularly cognitive. Cognitive rehabilitation is not part of post-stroke care typically. It's PT, OT, so physical therapy, occupational therapy, and speech therapy. And I didn't need speech therapy. I did physical therapy and occupational therapy for a year. And I kept saying to my neurologist, something's not right. My brain is different. I don't understand what's different. And I finally was able to get neuropsychological testing, which helped me understand what my brain was doing differently. And through that, I was able to kind of research what I had for resources, what was available to me. And I learned about music therapy. So I did music therapy for a year, and that literally took me from having seizures in the grocery store to going to the grocery store by myself. So there aren't a lot of resources, but if you dig in and you search, you can find things that work for you. And what we can do, we can talk openly about it. I talk about my stroke and my disabilities all the time, to the point where it's probably annoying to some people, but you never know who you're going to touch and who you're going to have that connection with. I met Devin at the NCIL conference in July, and I took an Uber from the airport, and the Uber driver said, "Oh, what are you doing here?" And I explained that I was there for the conference and I was a stroke survivor. And he stopped at a red light and snapped his head around and said, "Really? Me too." He didn't know that support groups were in his area. He didn't know about music therapy. He had his stroke in 2019, and there was a lot of resources that he was not aware of, and a lot of support that he could have gotten and his spouse could have gotten. So we obviously became fast friends, and I connected him with resources. So that's one of the many reasons that I talk openly about it. And that ties into the next item: make connections. It allows you to make connections inside and outside of our communities. You never know who has been touched by an invisible disability and how they can relate. There's a brain injury in the United States every 9 seconds. So every year, there's over 3 million new brain injuries in the United States. So you know somebody with a brain injury. You might not think that you do, or they might not even recognize that they have one, but you know somebody with a brain injury. Advocate and educate. We can teach people about invisible disabilities. We can educate and advocate on things that are really passionate and important to us. I'm sorry, I'm having such a bad word day. Just go along with it. So we can advocate for legislation that impacts people with disabilities, invisible disabilities. We can educate legislators, providers, any number of people on our illnesses and what we need. And then the other part of what we can do is that we can recognize that someone else may have an invisible disability. Yes, I am all about my own internal disabilities, but what about the person I'm talking to? Maybe they didn't have a stroke, but maybe they have an autoimmune disease and they want to talk about that too. So being aware that it's not just you, there are other people that you talk to that could have an invisible disability. Next slide, please. So I'll start with the NIH study portion of this. Adrenal dysfunction is very common after a brain injury, but it's not usually talked about. Stroke survivors have an approximately 2-fold increased risk of developing acquired hypothyroidism, pituitary dysfunction, or disorders of the adrenal glands. Very common issue for people post-brain injury is sleep. Insomnia is a bear. And I went to Boston and got an in-lab sleep study with Harvard-educated doctors, and they told me that I have sleep latency and I need to adjust my life around my sleep schedule. So basically, it means that my sleep schedule has shifted. That is not practical. The world is not going to adjust around my sleep schedule. So I met with a naturopath on a different issue, got it addressed, and then she said, "What else can I help you with?" I said, "If you can figure out my sleep, that'd be amazing." And she said, "Well, we can test your melatonin and cortisol levels." Well, I asked the guys in Boston about checking my melatonin levels, and they said that they couldn't do it. It was too unreliable. She said, "It's not unreliable. It's a saliva test. Here you go." And I've done it a number of times at this point. And I found out from that I produce basically no cortisol, which is the waking hormone. So that's why I was sleeping for 12 or 14 hours. It's because I didn't have the hormone to wake me up. And then I also was producing melatonin at the wrong times of day. I was getting this crazy spike that was like over what it even should be when you're sleeping at noon. So I was sleeping all day, most of the day, not getting the cortisol bump to wake me up. And then I was also getting a melatonin spike in the middle of the day. So she worked with me to sort of retrain my adrenals. We're still working through that, but that is a diagnostic that was fairly easy and straightforward, that my primary, my neurologist, the sleep doctors in Boston did not talk to me about. But if I hadn't said, can you help me with that? It would have, I would still be not sleeping. Because if I don't take medication, I don't sleep for 48 hours. I'm up for 2 days. It's happened multiple times. In that, I also learned that I have an anti-diuretic hormone imbalance. So basically that means that my body doesn't process electrolytes the way that it should. And it's not complete insufficiency so that I need like replacement hormones, but it's enough so that I can tell when I'm getting dehydrated. I get headaches because I'm dehydrated, because my body isn't processing. So I take more electrolytes to help balance that out. And when I don't, I notice. Next slide, please. Another topic I wanted to talk about today was post-stroke recrudescence. It's a very big word, but it really just means reactivation of symptoms. So I'll read the study part. The original study was at Massachusetts General in 2017. NIH just did a study on it last year. It was more of a case study. So from the Massachusetts General study, deficits were typically abrupt and mild and affected motor, sensory, or language function. Infection, hypotension, hyponatremia, insomnia, or stress and benzodiazepine use were higher during post-stroke recrudescence admissions. Yeah, I'll keep going. Compared with the control group, patients who did not experience recrudescence, the PSR group had more women, African American individuals, and those who identify as being from other races. So the analogy of how this happens, when you have a brain injury, there are cells in your brain, there are neurons that die. The neurons around the dead ones, as part of your recovery, pick up the job of those dead neurons. That's what recovery is your body is relearning and rewiring to make sure that you can walk again, that you can write your name again. Well, when the body deems something as a crisis, which in the body could be literally anything, lack of sleep, stress, blood sugar is off, high blood pressure, anything like that, those neurons are going to go, oh, no, crisis, we have to do our first job only. So they stop picking up that second job that they picked up. So brain injury survivors can get their symptoms back and feel like they're having another stroke or brain injury when it's really just that they're stressed or tired. And I hear this a lot in a lot of support groups. And once again, it's something that is not discussed. It's not talked about by providers. So it's very common in support groups, and it's important to me to educate people on that. Next slide, Devin. So why and how invisible disabilities work with the independent living movement. We talked about this a little bit in our introductions. There's a lot of shared experiences between people with invisible disabilities and those with visible disabilities, and how do those translate into finding resources and support. The compassion and understanding that I've learned from being a part of support groups translates over into the independent living movement. There's always different perspectives. There's a saying, once you've seen one brain injury, you've seen one brain injury. They are all different. Even if you have damage in the same place in your brain, your recovery and your outcome could be completely different. This also has just created a passion for impact for me. And I also recognize what I didn't have access to or what I wasn't aware of in my recovery. So I want to share resources and information with people as much as I can. And I think that's it.
Thank you so much, Jen, for being here and sharing your experience. I have learned so much from you and being a part of your world just since we met just a handful of months ago at Nickel. And I look forward to folks being able to ask you questions here after the rest of our panel.
Thanks.
So you're welcome. Thank you. Ashley, I'm going to queue up your slides next here. I'm going to make them a bit bigger. And I'm going to go off screen.
Hi, everyone. So I'm going to be talking about autoimmunity and POTS in the role of non-apparent disabilities. And why are we talking about POTS? I gotcha. Devin, next slide, please. So I do want to state POTS is a form of dysautonomia. It has been around for a very long time. However, awareness for POTS and dysautonomia grew a ton after and during the COVID-19 pandemic. It was estimated that about 10% of the general population was living with a non-visible or non-apparent disability. And something that was really crucial to remember is that non-apparent does not mean non-existent. Just because you cannot see symptoms and you cannot see how they impact someone does not mean that they don't exist. And I noticed in my own journey trying to get treatment, my physical condition, my physical disability, which is very apparent, is often treated with so much more compassion and validity than my experience after being diagnosed with POTS, a form of dysautonomia that you cannot typically see unless I become symptomatic. And that is what really kind of made me understand that we need to start transitioning and helping the medical system as a whole recognize that just because you cannot see something readily does not invalidate its existence. And also that we sort of need to bring awareness to and have a lot more compassion to how we deal with them. And hopefully that the medical professionals will start to see that just because you cannot see something doesn't mean that it doesn't exist or that we don't need support. Next slide, please. All right, so POTS has been around for quite some time, but public awareness of POTS, I noticed, really picked up after the COVID-19 pandemic hit. We were starting to see a lot of long haulers with COVID-19 develop POTS. And as that started to gain traction, doctors became a little bit more aware of it. But there is still a very, very lacking kind of foundational knowledge of what POTS is. And that certainly impacts the quality of treatment that we can receive as well. POTS stands for postural orthostatic tachycardic syndrome, which is a bit of a mouthful, but when you break that down, postural is talking about the position of the body. Orthostatics is when somebody goes from sitting to standing. Tachycardia means fast heart rate, and that is medically deemed as anything above 100 beats per minute. And syndrome is a collection of experiences. So all of these coming together is what defines POTS. And it's important to understand as well that even if 100 people have POTS, not everyone is going to have identical or even similar diagnosis because it is a very, very big range. Next slide, please.
It appears to be entering full screen mode, so hold please.
Not to worry.
There we go.
All right. so thankful I'm not on the technology end of this. All right. So something that has really stuck out to me is that POTS was discussed with me when I got the diagnosis, and they said, there is no cure. This is lifelong. And we have very, very limited options for treatment. Good luck. And kind of sent me on my way. And most of what I learned from POTS came from the community themselves, because I noticed the medical system treated me in that scenario. If there was not a cure, there was abandonment, in that the end goal was no symptoms, and that wasn't going to be attainable for us. So there was nothing that they can do. But that simply is not true. Just because there's not a cure does not mean that there's nothing you can do. Of course, if we can eliminate something, that would be great. But this speaks to symptom management and how managing symptoms can improve one's life quality. When I had nothing in my toolbox, I was suffering. I was unable to get out of bed. Doing each of my jobs was a hardship, and my mental health suffered. Until I realized that there were things that I could do to take an active role in kind of managing my symptoms. So this can look like wearing compression garments. This can be abdominal, as well as on your legs, so that it helps with the blood pooling. So when you stand, all of the blood drains from your heart, it goes to your legs and doesn't come back up, leaving your brain kind of under-oxygenated. A tip that I picked up as well is eating smaller meals more frequently. As we eat food, especially in a large quantity, the blood goes right to our stomach to begin the process of digestion, and it stays in the stomach, which means that it's not properly circulating throughout the body. Not enough is getting to your brain and your vital organs. Physical therapy and activity safely and with supervision has also been huge to sort of raise my tolerance towards physical activity, so that I'm not completely intolerant of movement, because we cannot be stationary all the time. And there are medications such as beta blockers that can sort of help regulate, the beating of the heart, and as well as keeping it from ranging quite so high and tiring out your cardiac muscle, because those bigger ranges over a lifetime can take quite a toll. Next slide, please. All right. So something that I was noticing is that POTS is often underdiagnosed or misdiagnosed because of the similarities and identities and identical nature of some symptoms versus another. So, for example, some very common symptoms of POTS are lightheadedness with or without syncope, which means passing out, um, palpitations, the tachycardia of the heart, it beating too fast, exercise intolerance, unable to sustain any physical activity long term because of that beating heart, and experiencing tremors, typically of the hands, and blurry vision. Those are symptoms that are seen in quite a number of other conditions as well. So I noticed that the nature was to start kind of at the top and work our way down to POTS. And I wonder if we will get to a time where perhaps we start at the ground level and work our way up. POTS can be seated as a singular diagnosis, but it is commonly seen co-occurring with other conditions as well, such as Ehlers-Danlos syndrome, mast cell activation, and gastroparesis, just to name a few. And because POTS is a form of dysautonomia. It is an umbrella label, which means that there is a lot under it, but it is describing essentially a disorder of the autonomic nervous system, which is responsible for those kind of automatic body responses such as heart rate, breathing, and those are some of the things that we struggle with. Next slide, please. All right. So I'm going to break down some of these numbers for you. As I said in the slide above, POTS is typically seen co-occurring with others. And this is a part of the reason why getting this diagnosis can be difficult because it does mirror other conditions, and it is sometimes easier to see the secondary symptoms than it is primary. So about 48% of people who are diagnosed with POTS also experience migraines. That is mirrored when somebody stands up and our body releases that epinephrine and that lack of oxygen and that headache. So that's kind of very common with migraines as well. And they do feel quite similarly, but also quite different as well. 21% experience Ehlers-Danlos syndrome, which is genetic. So typically one of your parents is a carrier, and Ehlers-Danlos syndrome is a connective tissue disorder. So the collagen that keeps everything tight and together unfortunately is not there. So there's a lot of elasticity, particularly around the joints. So these individuals will often experience a lot of subluxations and dislocations in joints that should be staying in place. Around just over 19% of people with POTS are also diagnosed with autoimmune diseases as well. And 10.8% of people that experience a POTS diagnosis have mast cell activation, which means that the body sort of overreacts to anything that's introduced to the body. It sees it as a threat, so it seeks to target it and attack it, which results in what we would commonly know as a allergy response. Next slide, please. All right. So what is the average time that it takes someone to get a POTS diagnosis? Unfortunately, the average time that we are seeing is that it takes about 7 years for someone to get diagnosed with POTS. I was very lucky that it took me about 2 years. I was discharging from the hospital post a surgical procedure, and I mentioned to my doctor, hey, this is what I'm feeling. He ordered an orthostatic test right away, which means that we test in real time what my heart is doing as I change positions, sitting, standing, walking. And I walked out of there almost with a diagnosis. He conveyed orally, I think this is what you have, and that springboarded into getting a series of testing. But I was very lucky that it happened fairly soon after wondering if this is what I have, because most of us are not that lucky. And hopefully, as we begin to raise awareness and speak about it, we can help bring that number down a little bit. Next slide, please. All right, so you have POTS. What the heck do you do if you're working and trying to maintain them, right? This is something that I myself am still trying to work around. I'm lucky that I have one job that I can do remotely, but I have another job that I cannot do remotely, and I'm noticing that I am symptomatic at that job. So what options do I have? I didn't want to have to quit because I couldn't do my job, so it made me ask, what can you do for me so that I can do my job, which is a simple question, although a complicated answer, but you should have an employer that is willing and able to accommodate you. So before you can get accommodations, I want you to ask yourself, how do you typically feel your symptoms? What are your specific job tasks and responsibilities? And how do the symptoms that you're experiencing interfere with your ability to complete and execute those tasks? Next slide, please. All right. So this is certainly not an expansive risk by any means, but persons with POTS who are experiencing it can often have increased fatigue, dizziness. Because of that, we are at a increased risk of falling. We have higher demands for schedules, and sometimes we have difficulties with our gross motor skills. So a very brief list of some accommodations that you can ask for is the ability to work from home versus in the office, work chairs that have armrests and no wheels so that you have support when you're going from sitting to standing, and it's going to have its own base that isn't going to wheel away from you. You should have access to fluids. So if you're working somewhere that, say, you cannot have food or drink at your workstation, this is an accommodation that you can have. It's one that I have at the hospital as well, because persons with dysautonomia and POTS typically need to drink about a gallon of fluid to help minimize its symptoms and get electrolytes sufficiently to the body. So there are things that you can ask for, but it starts with kind of identifying where it is that you need support and understanding that you have to advocate for yourself. That's all I got. So it's important to remember that invisible conditions are not non-existent. As the person experiencing the symptoms, you have every right to speak for yourself, and I encourage you to be patient with yourself through the diagnostic process. It's okay that you get fatigued, take a break, but do not ever stop. And that COVID-19 really helped raise and bring awareness to POTS, and yeah.
Thank you so much, Ashley. I feel like we have heard a lot of POTS, especially since the COVID-19 pandemic, and I'm glad you brought up long COVID and its effects on the dysautonomia community as well. So thank you. Looking forward to, I see some questions in the chat, so I'm looking forward to getting to that as well. I'm gonna stop sharing my screen because next up will be Jess Wilhux Cowing, and they have no slides. They don't need them. They're gonna just keep on chatting away. So I'm gonna hand it over.
Hello, this is Jess. Yeah, I do best just talking. It's funny, I just had a coughing fit because I know I'm dehydrated. And so I have my water right here. I finally got into a POTS clinic for February, so I'm like waiting to get that diagnosis, hopefully, and some more support. This stuff is real. So I think I'm going to talk about autoimmunity, what it means to have an autoimmune disease, some examples. I also want to get to the individual impacts in terms of the cost in waiting for a diagnosis. And I'm going to add in my experience as examples for some of this. I have a couple of reading recommendations after, if anyone finds that helpful. So first, a lot of you here might, I'm assuming a lot of you here live with an autoimmune disease, or you have a family member who does, but I think it's helpful to define like what that is, right? Like what is autoimmunity? What is an autoimmune disease? I should say I'm not a medical professional. I say this too in I'm like, I'm not a medical professional. I just spend a lot of time in doctors' offices. So, this is, I was initially, I should say, I had the onset of an autoimmune disease around 2011. So this is something I've been living with since then, and this is just what I've come to understand as someone who, I think it was Jen was saying, right, like having to do a lot of this on my own. So an autoimmune disease essentially means that, and this is like, there's so many autoimmune conditions, so this process looks differently for each one. But sort of a general description is that your immune system is so active. It's so active that it's responding as if it's in a state of crisis to respond to threats that it perceives, even when there's no threat there. So what this means is your immune system is recognizing healthy tissue as some kind of threat, and so it attacks your tissues, right? It essentially means your immune system is acting when it doesn't need to be, and the symptoms that arise as a process of that, that's what ends up, like, that's what autoimmune diseases are. And so this can happen in all parts of the body. As autoimmune conditions can be anything from myasthenia gravis to, I believe, type 1 diabetes is also an autoimmune disease. Many different kinds of arthritis are autoimmune forms of disease. There are really, really many kinds. I know the most about arthritis. I have an autoimmune arthritis condition. There are, I want to say, over 100 different kinds of arthritis. And something that I learned when I was 26 is that arthritis doesn't just affect old people. And this was shocking to me. I had no idea. I had never heard of it. I had no concept of this. So arthritis can happen as a result of sort of age, wear and tear, and use. Often that can look like osteoarthritis, like what your grandparents get, right? Or not even, you don't even have to be old to have osteoarthritis, but it's a kind of arthritis that happens from use, wear and tear, possibly different genetic components. Other kinds of arthritis are autoimmune, which means they're coming from your immune system being overactive and attacking parts of your body, especially the tissue around your joints, all the soft tissue around your joints, when it doesn't need to be. And that's what causes inflammation, redness, disfigurement. I hate that word, but changes to the shape of your fingers, bone damage, all of that. The kind of arthritis I have is psoriatic arthritis. It's two diseases in one. So you have both. It's exciting. You get a 2-in-1. Yeah, not exciting. So it means you have psoriasis, and it can be a minor case of psoriasis, or it can be extraordinarily overwhelming. And you also have an autoimmune arthritis component of that. It generally affects your hands, sometimes your knees, and your hands and your feet are the generally most affected. Of course, there are people who have all ranges of experience. For me, I have very little psoriasis, and I have an overwhelming amount of arthritis. As my rheumatologist reminds me frequently, I have a very aggressive case of psoriatic arthritis. For some people, the onset, it can be at any age. There are juvenile forms of arthritis. There are kids who have arthritis, and it's generally in the autoimmune category when that happens. I wasn't a kid exactly, but I was 26. I had been a really healthy kid, like to a point where it was like a concerningly healthy kid. Like I rarely got sick. I had the flu like twice that I can remember before age 18, and that was it. I was just a healthy person. And then in my early 20s, this is not the norm, I should say, but my experience was I woke up one morning and felt like I had aged 70 years. That's what happened to me. It can look like that. It can be a sudden onset, And even that sudden onset, there were things that had happened prior to that that I wouldn't have recognized at the time as symptoms of an autoimmune disease. But in hindsight, I can look back and say, oh, actually, this started a few months before with weird feelings in my fingers, like twinges I hadn't felt before. I just wasn't able at the time to recognize it. But there was a really overwhelming component where almost overnight it felt like I didn't recognize my own body. I felt stiff. I couldn't move. I had searing back pain in the middle of the night. So of course this is affecting everything, right? Um, and some people have a gradual onset, right? It's really, really different across different people and across different diseases and their manifestations. Um, and so something to think about with autoimmune disease, and I'm thinking of, I think it was possibly Jen who said this, a lot of it you are figuring it out on your own. So what that can look like is I'll use myself as an example. I was a 26-year-old graduate student. I had crappy health insurance. I was a healthy young person up until that point. So I really had the type of health insurance, and this was before the Affordable Care Act, where a lot of people didn't even have insurance. And so the insurance I was able to get was like the student offered insurance, which basically covers like a portion of your emergency room visit and pretty much nothing else, right? So you're paying out of pocket for a lot. So when I started feeling sick over a summer, I went to the student health center, and I went 2 or 3 times. They didn't really know what was happening. And I think finally on the third time, the doctor who saw me said, maybe you should see a rheumatologist. And I was like, I don't even know what that is. So I just looked up, closest rheumatologist. I did get a diagnosis. It ended up being not the correct diagnosis. The thing about autoimmune diseases, following what Ashley was just saying, it is difficult to diagnose autoimmune conditions because there are some common symptoms across the board. And a lot of them are degenerative, where they get, not all of them, but some of them, like it takes time to sort of see like, okay, you started here and now you're here. This is what's happened. So initially I was diagnosed with rheumatoid arthritis, and I was given a medication course that would fit that profile. Um, and the thing about my version of psoriatic arthritis, and the thing about a lot of autoimmune diseases, is it's really, you're in a tough spot, right? Because it takes a long time to get diagnosed. At the same time, a lot of autoimmune diseases do the most damage in the first few years when you have it. So when you have, and this is what happened in my case, I had what I now see as like bone destruction that was happening in the first 2 or 3, and really in the first year that I had the onset, but I didn't have the right treatment. And so that's how it was allowed to progress, right? The kind of arthritis I happen to have, I know now, was aggressive to the point where I would have needed medical intervention like immediately when I started having symptoms, but there was no one to recognize, oh, this is what's happening. And so a lot of the disability that comes from my version of the disease is actually like truly because it took so long to finally get the right diagnosis and to get a practitioner, a rheumatologist who saw what was happening and was like, we need to treat this aggressively. So the disability I have now is mostly in my hands. I think I have beautiful hands. And it took a long time to feel that way. But you can see my fingers have different shapes. I'm a small, petite person, and I have really different shaped fingers, right? This is a result of bone damage. The bones, and I know this from my x-rays, have altered in all of these fingers. And a lot of that came from the early years when I didn't have a doctor recognizing what was going on and what I really would have needed to prevent that. So autoimmune diseases, a lot of the symptoms are a lot, or I should say, a lot of the treatment is sort of aimed at preventing future damage and to sort of minimize the symptoms you experience. And that can take a toll on people. I've had this happen. A lot of the medications, especially for the more aggressive forms of autoimmune diseases, are coming from biologic medications, which are injections that you inject yourself or you receive through an infusion. These medications are essentially like there's a monopoly on them. They're like very few patents are extended, and a lot of them have a brand name, but not all of them have a generic version. These medications out of pocket cost, I'm not kidding, $5,000 to $10,000 a month. And so think about that. Before the age where people had insurance, folks who had this kind of autoimmune disease, and this still happens even with the ACA, essentially had to sort of accept, I'm never going to get the kind of treatment I actually need, right? That's a lifelong disabling condition. If you have insurance, sometimes it will cover a portion of that. What a lot of people have to do, and I've spent time doing this, is troll the internet for any kind of organization that will give you essentially like a stipend to pay for your medication. In order to get that, you have to submit a lot of personal information. You know, your salary, your income, just a lot of personal information, right? That's how people get those medications sometimes. I now am in a better position where I have a good health insurance plan and it covers my medications, but I've had a lot of instances where just changing my insurance because of job insecurity can basically completely disrupt my medical treatment and could change the course of my disease and my health entirely because of what access I have to health insurance. So I think that's a really important part of understanding autoimmune diseases, and the impact is that, right, like not everyone has access to health insurance. Not everyone lives in an area. Rheumatologists, good rheumatologists are far and few between. There's parts of the US where people are traveling like 4 hours, more than that, to get to their closest rheumatologist, especially for the juvenile forms that affect kids. I happen now to live near one of the highest, I live near Hopkins, and I have this awesome Hopkins rheumatologist. I would strongly recommend Dr. Anna Maria Orbai. That's Orbai. I'm one person and I've had a great experience with her. She's been the only physician who has actually recognized what's going on and has gotten me to a place where I feel managed, right? I mean, not in a bad way, but like my arthritis is managed. I haven't felt this good since I was like in my early 20s, in terms of my arthritis, right? And so I would recommend her if you're in the area or if you're willing to travel to Hopkins or able to. But that's just the thing, right? There are people who travel from and fly in to get treatment at places like this. There aren't enough rheumatologists in this country to really adequately address the rise. Sometimes it's referred to as an epidemic of autoimmune diseases. That's mostly what I wanted to get to. Can someone let me know if I'm running out of time or what the time check is for my portion?
You're good. If
Oh,
you, yeah, no, sorry.
great. I can talk a
No.
lot more. So these are just factors, right? That like living with an autoimmune disease. I know a few of you in the chat are asking about like, how do I support people? How do I understand? A lot of it is just understanding just the limitations, right? If you're a young person with an autoimmune disease, I have a supportive family, but I also had to do a lot of this on my own, right? When I was 26, I had to figure out how health insurance works. I had never had to on my own do that before. I had to at 27 figure out how to appeal a health insurance claim, right? Because I was charged for something I shouldn't have been charged for, and I had no money at that point. And so, right, like an extra $100 bill was really like could tank my finances for the month. And so I had to figure out how to appeal it. These are things that young people and people of all ages deal with autoimmune diseases. A lot of the things that folks have talked about so far, and I've learned so much from all of you, in terms of being dismissed, not being recognized, having a long time to get a diagnosis. A lot of this is kind of just inherent in the way that, one, health insurance exists in its current form and the origins of health insurance, and also the way that our medical system is so highly specialized, right? That it literally prevents people from seeing the big picture. Right? So like for folks who have who have the kind of insurance where to see a specialist, you have to have a referral, right? That's a whole separate doctor's appointment to go to your primary care to, one, explain what's going on, two, have them believe you, right? Which, like, depending on your race, depending on how you present to the world, depending on your communication style, that's not a guarantee, right? We know that. And so you have to go to primary care, get a referral, and then go see a specialist. A lot of us know this. If you are trying to see a specialist for the first time, you can have a waiting period of up to a year. So if you are like me and most of your destruction happened in your first 1 or 2 years, that's how a lot of people end up with lifelong disability, entirely because of waiting periods. Once you get in with a specialist, it's easier to have more frequent care, but just getting a new appointment with a new provider, it can take a year or so or longer. And so these are things that really, really impact how much someone's autoimmune experience, right, is affecting their day to day. Folks here have mentioned like struggles with jobs. I've had that too. Right? If you, I know a lot of people too, when you have expressed this, I'm thinking about diagnosis, right? And diagnosis, if you don't know what's going on, right? I mean, you know what's going on in your body. I'm experiencing this. I'm experiencing this. If you don't have a label or a diagnosis, it really, really limits how much you can advocate for yourself and push for different testing and push for different treatments. So for a lot of us, getting a diagnosis, I mean, this can be, I'm not even getting to like mental health conditions, which there's a way that it works there too, but when you don't have a diagnosis, it makes it harder for you to advocate for yourself. I remember when I was in 2011, I was getting a master's degree in English at Cal State Long Beach. I was a graduate student. I was a young person. I think I had like student loans, and I was also teaching a college course for the first time. The first time I taught a college course in the fall of 2011 was the fall that I was experiencing most of the onset of my autoimmune disease. At the time, I did not know what was happening to me. I was waking up some days not able to move, not able to walk, not able to hold a marker and take the cap off, feeling tired in a way that I knew there was something extremely wrong, but I didn't know it was happening. So I didn't know how to ask for support because I didn't even have the language to know. I was like, something's happening. I have no idea. And because I don't have the words or language or framework, I don't know how to explain that to other people. And it wasn't until 2013 where I moved across the country back to the Maryland, DC area, where I was finally diagnosed with psoriatic arthritis. And that's when I was like, okay, I had a misdiagnosis. The first rheumatologist was in the region, right? But not exactly. Now I know exactly what I have, and I have more. Then now I can research it, right? I can research it. I'm a researcher, so I do this for everything in my life, right? I can look it up. I can see what supports are available. Without that diagnosis, it really limits the services that people can ask for, right? It limits your own understanding of what's happening, right? It's such a relief sometimes just to know what is happening, right, with your body. And I think that's a huge aspect of living with an autoimmune disease. And it's a huge aspect of what adds to just the disabling experience if you're someone trying to like understand what your family member might be going through. So these are just some things to, I guess, think about. Um, I would recommend the book The Invisible Kingdom by Megan O'Rourke. She's a disabled person who I believe has, she may have Ehlers-Danlos syndrome and POTS, and she's had dysautonomia, and she struggled for decades trying to understand what was going on. And then she wrote a book about it, and she's interviewing a lot of people like us who have just had these like decades lost to question mark, don't know what's going on. And she has so much information in there that's really helpful for non-specialists, right? If you aren't a medical professional, if you aren't you know, an academic, some of it is dense, but a lot of it is aimed at a general audience for people to just understand more. And so I think that book is helpful. I'd also recommend the book Inflamed by Rupa Maria and Raj Patel. It's two, I think, one journalist and one practitioner writing about the need for healthcare that can see the bigger picture, right? Right, because it gets people resources faster, all of that stuff. I will say there's like one tiny mention of autism in a curative gross way in that book. It's very brief, and it's more in the realm of like they're talking about preventative things. So just as a small caveat, but overall, I found that really, really informative. And again, it's written with people in mind who aren't medical professionals. So I think it's more accessible than other things. I can stop there, but I'm happy to answer more questions during the Q&A.
It's just, and if you don't mind putting those book titles in the chat for folks that may want to grab those, that would be fantastic. And next up, that was so great. I'm looking forward to grabbing those books myself. Natalia, I will share my screen and we can get to your presentation.
Hi, everybody, and thank you all to the panelists for those excellent presentations. I hope I can meet that standard. So yes, my title for now is Patients as Active Inquirers, Gender, ASD, and Autoimmunity. Again, my first name is Natalia. My pronouns are she, her, hers, and ella. And I'm currently a Mellon postdoctoral research fellow in disability justice at the George Washington University. So quite akin to Jess, I'm approaching autoimmunity really from personal experience and from anecdotal storytelling. So I'm not going to be focusing so much on my research, but as it pertains to my personal experience, I'm hoping that the next couple of slides can be helpful. And just to give an image description of the first slide, I included an image of a doctor, a clinician interacting with her patient. So these are two women. On the left-hand side, you will see a light-skinned doctor with long brown hair and a ponytail, and then next to her, it's not immediately apparent, but on the right-hand side, this is a wheelchair user who's wearing a bun and has kind of, I'd say like olive tone skin, and it's against a peach background. So next slide, please. It should be titled Personal Experience with Psoriasis. So yeah, so a little bit about me. So I developed symptoms of psoriatic disease at the age of 4. And I only have psoriatic disease. I don't have co-occurring arthritis. And as Jess obviously underscored with their personal experience, that's often a co-occurring symptom. So at a very young age, there was some evidence, right, of chronic inflammation. And what's important to know about psoriatic disease is that it's not just a cosmetic problem, right? It often shows up as scales, as plaque psoriasis. Sometimes there's guttate psoriasis. So those are circular lesions that tend to be smaller, and they can often follow illness like strep throat. And I'll talk a little bit more about that later. So autoimmune disorders run in my family, especially among women. There have been cases of multiple sclerosis, lupus, and polymyositis. And polymyositis, for those of you who are not familiar, that is somewhat akin to muscular atrophy, but basically it's a progressive autoimmune issue that essentially affects just your muscles and eventually your mobility if it's not treated in a timely basis. And I think I guess many people who live with an autoimmune condition, they experience very moderate to severe flare-ups when they're going through emotionally and psychologically trying moments. And then I'll go later into how some of my learning difficulties also contributed to those stressful moments. But what I recall is that during SAT and college application season, right, because I was navigating all the difficulties, right, of preparing for a college education as somebody with executive functioning issues, which in turn affected my learning. So what I noticed in high school was that I just had really significant flare-ups. I had them on, I had psoriatic lesions on my stomach, all over my arms. They were red and they were really uncomfortable. And I would use topical ointments and salicylic acid. And I remember that the medicine would just make my skin burn and I would just be like writhing in pain. And that would happen, first thing in the morning. I would, put on my medication, and then I just had to deal with just really just feeling I was just in pain. So so yeah, even not and topical ointments don't always work. I believe that there are some sort of with a sort of a vitamin D basis, and then obviously with steroid cream, which you can only use intermittently, right? For 2 weeks, or that can also atrophy your skin. So it's just it's a process. So another thing that happened to me during my master's program, this was when I was in my early 20s, my grandparent died of gastric cancer right at the beginning. This was the first semester and of my master's program. And again, my psoriasis it just spread. It went from, I guess, fairly unstable, under control, and then it exploded. And I'm not sure if you are familiar with the Kovner response. So I acquired a burn while cooking, and this is essentially what happened. So a Kovner response is a rapid development and or spread of psoriatic lesions after a skin injury. And once again, it started off as a minor lesion, and then it spread throughout my arm. This entire part of my arm was covered in psoriasis, sorry. So yeah, and what I also noticed at that point is that I was having some difficulty with my graduate classes. I started taking incompletes. So there was just a lot of stress-based responses that were implicated in the spread of these psoriatic lesions. And then during my doctoral dissertation phase, after a health scare, I developed scutate psoriasis, which what I mentioned when I mentioned previously that those are like the tiny circular lesions that just spread throughout the body. And yeah, so that was, and now it's a little bit more stable, but I went through that period as well. And then more recently, another grandparent of mine passed away, and then I had a flare up after that moment. So there is an emotional stress-induced component to this. Next slide, please. So because I'm going to talk a little bit about ASD, and just to emphasize that I am not a clinician, and there may be moments where I'm perhaps using some medical terminology, maybe not in the right way. So I wouldn't be surprised if I got some pushback from a researcher, but I'm just going to explain the following to the best of my ability. So I was diagnosed with ASD level 1. And then I had previously been underdiagnosed with ADD and co-occurring generalized anxiety disorder. And like I mentioned before, in graduate school, what I sort of noticed about sort of those aggressive flare-ups, that's when I started having what are called autistic meltdowns. So I would have these crying spells, I would have these panic attacks. And those symptoms, I guess, those symptoms of mental health struggles, they co-occurred with these flare-ups. So just through my independent research and my readings, especially sort of leading up to the point where I realized that I needed to get a neuropsychological evaluation for ASD, I realized that during the latter part of my doctoral program, I just started looking up information, I guess, especially written informally by neurodivergent women on the spectrum. And they were all mentioning, the co-occurrence of autoimmunity, how common that is among women and women presenting people. And I've even read through some of my research looking at open access materials and NIH materials that psoriasis especially is one of the most common autoimmune issues affecting people on the spectrum. So I did learn that there does appear to be a link between autoimmunity and ASD. And in my estimation, and I want to insert a caveat here, I'm not denying the critical genetic component to the development of psoriatic disease, but biology alone, in my estimation, so merely a DNA-based inherited disorder, that doesn't fully illuminate what's happening. So, why does ASD often co-occur? So, and I think what I try to emphasize in my dissertation is that there is a strong epigenetic component and trauma-based factors that are implicated in autoimmune disorders and its corollaries like anxiety, panic attacks, mood disorders, etc. And yeah, so it's not just this issue of co-occurrence, but even prescribed medications can induce a flare-up. Sometimes there are contraindicated prescribed medications that can exacerbate symptoms. So it's not unusual, and especially with these subspecialties, right, that a psychologist or a psychiatrist is prescribing a medication like lithium to address, I guess, potentially a more problematic disability in the way that it's framed, unfortunately, in society. And completely sort of ignoring the possibility of chronic inflammation as a causal mechanism that is contributing to this symptomatology. So, for instance, in the case of neuropsychiatric systemic lupus, for instance, there can be a period of transient psychosis attributable potentially to neuroinflammation, for instance. So I remember, especially through that episode of guttate psoriasis that I referred to during my during the dissertation phase. So I approached my dermatologist, and an experienced dermatologist. I'd been seeing him since I was a kid, since I was 7, and he just categorically denied, the potential link between ASD and psoriatic disease. He just flat out said, "Nope, there's no link." And yes, and that I obviously disagree with that statement. So in general, though not always, I do find that women and women presenting clinicians tend to be a little bit more receptive when I proffer an anamnesis. So just for, just to clarify the terminology, that's anamnesis refers to a self-reported medical history. So that what the patient reports to the clinician. And there's a little bit more acknowledgement of that, of the potential validity, right? You still need to consult your clinician about, the diagnosis, but, and I'll talk later on, and I'll be citing a philosopher, Quil Kukla, who is a philosopher at Georgetown, about the importance of informed decision-making, and just being not only an informed patient, but allowing a clinician who is receptive to learning about your symptomatology, the way that you experience it. That interaction is critical for making informed decisions and being an autonomous patient. So what I would recommend before going into Kukla, the passages from Kukla's paper, just basic internet sources, not AI, but looking into peer-reviewed open access materials that are grounded in rigorous research. JSTOR has a database on this. NIH also includes articles. They're jargony, but I think, with just reviewing and rereading, I often have to do that. You will get moments of clarity, and you will be able to inform yourself to just empower yourself to make sound medical decisions in consultation with your clinician. And I also think that being an informed patient also offers opportunities for clinicians and researchers to conduct additional work in the subfield of psychoneuroimmunology, right? So an interdisciplinary approach that allows an opportunity to parse those links between neurological symptoms and then, immune-mediated conditions. Let's see. Next slide, please. It's slide 5. So I just wanted to read out some passages that I think are really meaningful, and I will share the link to this article. Kukla is a really important philosopher who gets into feminist approaches to bioethics and the importance of a more equitable dynamic between patients and clinicians to lead to an accurate diagnosis. So I think this is a really powerful quote, and I read, "We cannot make high quality informed decisions about our own health unless we have access to an expert who can provide a synthetic assessment of our particular medical situations. However, even financially secure North Americans face a healthcare system," and this is what Jess was referring to, a healthcare system that is increasingly fractured by specialization, discontinuity of caregivers, and elaborate divisions of labor among health professionals. Hence, there may be no one person who is in a position to make a judgment about a person as a whole. So, two more quotes that I think are just really telling about how clinicians are sort of predisposed to not necessarily trusting the judgment of their patients. So this first quote says, 84% of clinicians rate their patients fair to poor at appraising the quality of the information they find on the web. And almost 3 times as many clinicians believe that patients' independent research hampers the efficiency of clinical visits that believe that this research improves efficiency. And then they go on to explain, to make a dramatic example, consider a psychiatric disorder recognized by the DSM. So it's called factitious disorder imposed on another. So referring to mothers who are so-called hypochondriacs who apparently either fabricate obscure physical symptoms for their children or intentionally inflict physical damage on them to get attention from medical professionals. So a series of exposés over the past few years have shown that this factitious disorder is overdiagnosed and sometimes deployed against mothers. It's kind of used as a clinical weapon to that's used against these very irritating mothers, right, who insist on a different diagnosis, and really what this speaks to is clinicians' assumption that just actively questioning a potential diagnosis that's seen as pathological defiance or denial, right? And I will finish here because I know we don't have a lot of time, but just this last quote, which I think speaks to the importance of a more equitable interaction between clinicians and patients. So the last quote, and this is the penultimate slide, the 7th slide before the source. So good medical decision-making requires the judgment and skilled expertise of practiced clinicians. But at the same time, clinical practices should reflect an expectation that patients may be active inquirers who bring relative expertise and a healthy critical distance from the authority of their physician's voice into the clinic with them. And this last part I think is super important. Clinicians should respect and recognize their patients' capacity for autonomous inquiry and give these patients reasons to trust their expertise when appropriate, rather than assuming that their voices will be heard as unilateral and immediately authoritative, right? So coming in with a perspective, a patient is not seeking to impose a different view, but is seeking an interaction that would enable them to make an informed decision, not only about themselves, but also as caregivers. So this is the source. I'm just going to put it in the chat. And I hope that it's useful for Kukla's paper. Sorry, Damon. What was the term that you wanted me to repeat? The term related to informing clinicians about one's anamnesis, a patient's self-report of their medical history. Here we go. Thank you all.
Thank you. Oh my gosh, that was so much information. Thank you so much. I feel like everybody brought so much to the panel, and I know that we have so many questions in the Q&A, and unfortunately we are just about out of time. Just real quick, I want to talk real quick about the All of Us research program and how it connects directly to the conversation that we had today. All of Us is an initiative from the National Institutes on Health to create the country's largest and most diverse health research database with the goal of enrolling 1 million people or more. As of today, more than 839,200 people have joined the program. More than 88% of those participants are from groups that have been underrepresented in health research in the past, with over 28% of those participants identifying as living with a disability. And that is the goal of the program, to ensure those who are historically underrepresented, such as racial minorities, sexual and gender minorities, those living in rural areas, and disabled individuals from all communities being included in health research. Currently, before the webinar even started, I checked the database. There are 232 research studies right now being done on autoimmune conditions on the All of Us research portal right now. So the research is being done. They're not waiting till they get to 1 million. They're digging in right now to get to that precision medicine and make some changes happen for the community. So you can learn more about the research currently being done at the link in the chat.